everybody. Thanks for coming today. I know we're all the way in this building. We're usually over in Ed 2 North. Just scheduling wise, we couldn't get a room there. So thanks for making the trek all the way down here. I just ask you to please sign in. There's a couple sign-in sheets. There's one there. There's some on this side. Just please sign in. Just only quick announcement that I have is just next month's Grand Rounds. We have Dr. Judy Schley, who's the Associate Director of Denver Public Health, coming to speak about public health accreditation. So it should be a really interesting talk. That's on December 2nd, and that's back in Ed 2 North. So I'd like to introduce our speaker today. Dr. Christina Nelson is a medical epidemiologist at the Division of Vector-Borne Diseases at the CDC in Fort Collins. She received her bachelor's degree from the College of William & Mary in Virginia, a medical degree from Case Western Reserve University, and her master's in public health from Colorado School of Public Health a couple years ago. Prior to her position at the CDC, she lived in Peru and studied viral encephalitis as a NIH Fogarty International Clinical Research Fellow, and that's what she'll be speaking with us about today. She's board certified in pediatrics and preventive medicine. She's actually a graduate of our program, so we're happy to have her here today, and hope you enjoy the talk.
Hi, everyone. Yeah, thank you so much for having me, and especially thanks to Carolyn and Tracy for inviting me to speak. Like Tracy said, I did my preventive medicine residency here and got my MPH here at the School of Public Health, and so I have lots of fond memories, and it's nice to be back. So yeah, now I work at the CDC in Fort Collins, and so most people think of Atlanta when they think of the CDC, but there is a small outpost in Fort Collins with about 200 employees, and it's mostly, it's a majority of the Division of Vector-Borne Diseases. And within that, I work in the bacterial diseases branch, and so we work a lot on Lyme disease. We also cover plague, tularemia, Bartonella, tick-borne relaxing fever, and some other infections, so it's pretty fun. So, like Tracy also said, today I'll be talking about some research I did prior to joining the CDC. So first of all, I'll start off with a little frame of reference, just a map and some pictures and background about Peru, where I was for this research. And some of you have probably been to Peru. This is a map of South America, and so as most of you know, it's on the western coast of South America, borders Ecuador, Colombia, and Brazil. The population is about 29 million people, and Lima is the capital city with about, last time I checked, 8 million people, so probably a little bit more by now. So almost a third of the population actually lives in Lima, in the capital city. And Peru is really an amazing country. It's not a huge country, but it's extremely geographically diverse, and so all up and down the coast, you actually have coastal desert. Even though it's on the coast, it's very dry. It's often very cloudy due to the Humboldt current coming up. It's cloudy and sometimes drizzles, but it actually very rarely rains. So it's actually a desert right there on the coast. Up in the northeast, you have the Amazon jungle region, and Iquitos is the main city in that region. It's the largest city that is not accessible by road. You have to take a boat or a plane to get there. And then in the southeast, and all through the country actually, you have the Andes Mountains, and in the southeast, Machu Picchu and Cusco and most of the other places that you've heard about. So this is a picture of Lima. Like many capital cities, it is a very big, dirty city, but it has a lot of redeeming qualities as well, and we really enjoyed our time there, and it has great food. So this is a picture in Miraflores, which is right on the coast, and the nice sunset and the ocean that you can see. Many people, when they think of Peru, think of Machu Picchu, which is an amazing place, but Peru is not just Machu Picchu. This is a picture of Arequipa, down in the southeast in the Colca Canyon, which is a really beautiful area, and you can see Andean condors and other things, some really stunning scenery. So there's just really a lot of things to do and beautiful places in Peru. And of course there's beautiful, amazing people, so it's really nice to meet all the people there and all the different populations. So a little primer on infectious diseases, specifically in Peru. The under 5 mortality is 21 per 1,000 live births. By comparison, in the US, the mortality is 8 per 1,000, so it's significantly higher. The leading causes of death in children, the leading infectious causes are pneumonia. It's the third leading cause of death in children. in Peru. Diarrhea, neonatal sepsis, and malaria also top the list. There are about 31,000 new cases of tuberculosis per year in Peru, and about 5 of those are multi-drug resistant. It's a huge problem in Peru. Have any of you read Mountains Beyond Mountains? Yep, probably lots of you. You'll probably remember that they actually have done and still do quite a bit of work in Peru, mostly related to MDR TB. And there are various outbreaks of infectious diseases. Yellow fever, dengue, Bartonella bacilliformis causes Carrion's disease. The acute form is Oroya fever, which causes hemolytic anemia and has a high mortality rate. And the chronic form is Verruga peruana, which causes really horrible growths that are very vascular and bump. If you bump it against something, it bleeds. And it's an interesting infection, and there's a lot of knowledge gaps with that infection. Measles, cholera, there was a cholera outbreak in 1991, and just lots of other infectious diseases that cause problems in this and many other countries. So the objectives of this talk, first of all, I'll review viral encephalitis, including the existing literature on surveillance, which plays into our research. I'll talk about the protocol of our research and the results of a large hospital-based encephalitis study currently underway in Peru. And then I'll talk about future research directions, nested case control study, and herpes genetic studies, and some other things. I'll also talk a little bit about the fellowship, since some of you may be interested in that in the future. So a little bit of background, encephalitis, so itis, as many of you know, just means inflammation. So encephalitis is anything that causes inflammation of the brain. The classic presentation is a triad of fever, headache, and altered consciousness. But actually, a lot of patients with encephalitis don't present classically. They can present very differently, so it can be hard to catch sometimes. The most common infectious cause that we know of is viral infection of the CNS, the central nervous system. Other causes, bacteria, for example, tuberculosis can cause encephalitis. Immune-mediated causes, there are certain potassium receptor channel autoimmunity that can cause encephalitis, and there's a lot of research related to that. Metabolic disturbances, adverse medication effects, malignancy, there's lots of different causes. But in the majority of cases, the vast majority actually, an etiology is never actually identified, surprisingly. So a little bit about disease burden. In the US, encephalitis causes about 19,000 hospitalizations per year, almost 250,000 hospital days, and 1,400 deaths. But the worldwide data is limited, and I'll talk a little bit more in future slides about why, especially in developing countries, we actually don't know a lot about encephalitis burden and patterns. Mortality rates are high even with treatment, 7 to 11%, depending on the infection or whatever's causing it. And subjects who survive often have chronic neurologic sequelae, and this includes memory loss, seizures, emotional disturbances, and other things. And so it really, even in patients who do survive, it really causes significant morbidity as well as mortality. So viral encephalitis specifically can be caused by over 100 different pathogens. There's really a wide variety of etiologies for it. The severity and the incidence and the distribution, transmission, seasonality, risk factors, everything varies widely and varies depending on the pathogen. It can be sporadic, or there can be epidemics of encephalitis. And this is just a list of the pathogens. I won't go through them all, but as you can see, varicella can cause encephalitis, HIV, the arboviruses, Japanese encephalitis, dengue, influenza. Encephalitis is a rare but very serious complication of influenza. Both seasonal and epidemic influenzas can cause it. Measles, rabies, tick-borne encephalitis, and some other arboviruses. And again, this is just a sampling of the many causes. So the clinical presentation, the common clinical findings include disorientation, so neurologic signs. So patients come in disoriented, they may have behavioral or speech disturbances, trouble swallowing, other neurologic signs that can be focal, for example, cranial nerve disorders, or general, such as seizures. And the term meningoencephalitis is sometimes used because the presentations can overlap and sometimes the infections can overlap. So meningitis is, the definition is, it's an infection and inflammation of the meninges, which is the covering of the brain, and the subarachnoid space. And the typical triad for meningitis is neck stiffness, along with fever and neurologic signs that were less apparent. So again, often meningitis is isolated from encephalitis. They have different infection patterns, but sometimes they can overlap both clinically and with the actual infection. The key to distinguishing between the two, if you can, is the presence or absence of abnormal brain function. So if someone's having abnormal brain function and you've controlled their fever and you've controlled other reasons for that, then it's probably due to an actual infection of the brain. And the symptoms of encephalitis are due to cell edema, so cell swelling, and death. So the brain cells are actually being infected and dying. This is an example of the devastation that viral encephalitis can cause. So this is a patient who actually had H1N1 encephalitis, and so this is at acute presentation, and this is 1 month later after recovery. So as you can see initially, this patient's brain is very swollen. Usually the brain has very nice kind of ridges and peaks and valleys almost, but it's very swollen. Those are not apparent. And then the ventricles are being compressed because of all the swelling, and then the white matter is really lighting up. It's more white than you would expect, and that's a sign of inflammation. So this patient was extremely sick and did survive. This is 1 month, as I said, post acute infection, but this is a 20-year-old patient, and this really looks like the brain of an 80-year-old. There's a lot of atrophy. As you can see, the brain, the sulci, or the kind of valleys in between the brain tissue, are very deep, and there's loss of brain tissue. And so this patient did survive, but still needs assistance with activities of daily living, such as eating and cleaning, showering, and stuff like that. So it's really unfortunate, but this does happen with a variety of infections. So the treatment options for encephalitis in general are pretty limited. For certain infections like herpes and varicella, acyclovir does work. It works very well. For influenza, you can treat patients with oseltamivir or amantadine, depending on the influenza strain. But for most other viral causes, so all the arboviral causes and many other causes, there is no treatment, unfortunately. And the treatment really is supportive care, so they may need to go on a ventilator, monitor their intracranial pressure, because as you saw, there's usually lots of swelling, sometimes steroids and anticonvulsants. So specifically, a few words about HSV, herpes simplex virus. So HSV type 1 is typically the oral form of the virus, and by the time you're adults, 85% of people are infected. And usually it's a benign infection. Sometimes it causes people to have cold sores. That's usually the cause of cold sores. And after infection, it just incorporates itself into the nerves and lies dormant. And then, for example, people who do get cold sores, if they're stressed, it can kind of reactivate and cause a more acute infection. But most people who get it have it forever. HSV2 is typically the cause of genital infections and genital sores and genital herpes, and can be passed from mother to child and cause very severe infections in newborn babies. These are the typical categories, but actually they can overlap. So HSV1 can cause genital herpes and vice versa. HSV1, when it does cause encephalitis, so 85% of people are infected, almost everyone. And herpes encephalitis is quite rare, but very severe. And when it does happen, it's thought to be that the virus spreads. Like I said, it lives in the nerves and spreads from some of those peripheral nerves back to the central nervous tissue. There's no seasonality for herpes encephalitis. It does have a biphasic age distribution, so younger and older patients typically are more at risk. But other than the age distribution, the risk factors are generally unknown. Like I said, so many people have it in their mouth, and a lot of people actually have genital herpes, but we don't know why some people go on to develop encephalitis and why the majority don't. Herpes encephalitis is a very severe infection. It has about 70% mortality without treatment, if patients do get acyclovir in a timely fashion, then the mortality goes down to 19%. So really a substantial improvement with treatment, but 19% with treatment is actually still very high mortality. And after infection, those who do survive, only about 38% return to normal function. So there's a lot of morbidity and long-term sequelae as well. This, of course, is a post-mortem sample of a brain of someone who had herpes encephalitis. This is looking from the bottom of the brain, so this is the front. These are the frontal lobes. Herpes very typically concentrates in the temporal lobes, and so as you can see, this is a horrible infection, and the temporal lobes are just swollen and bleeding and cause this patient to expire, and it's really a devastating infection. So in terms of viral encephalitis surveillance, just kind of the big picture, what's missing and why was this research started? So encephalitis is very difficult to study because it's rare, it's often sporadic, and the symptoms can start off nonspecific. Case definitions can vary, and laboratory diagnosis is expensive. Usually you have to use PCR, sometimes you can use serology, but there's so many different causes, it's hard to know what to test for, and it's hard to have tests for everything. There have been large surveillance studies in England and California and France, but there have not been comprehensive surveillance studies in the developing world. There is one study that has been going on in Vietnam, but it's only at one children's hospital, so it's not really a countrywide large surveillance study. And really, in developing countries, there's just outbreak reports and disease-specific surveillance. There's not really comprehensive pictures. So the objectives of the surveillance and the study in Peru, number one was to determine the relative frequency of infectious etiologies of viral encephalitis in Peru. And really, aseptic encephalitis is probably the better term because we did test for other causes of encephalitis like tuberculosis and cryptococcus and things that don't cause bacterial, the typical bacterial picture, but do cause encephalitis. Number two, describe the risk factors and clinical presentation associated with these different causes. And lastly, enhance laboratory capacity, so capacity building in Peru for assessment and treatment of patients with CNS infection, and also building collaborations. So this surveillance study was initiated in February 2009. Joe Zunt at the University of Washington is the PI on this study, and so he got an R01 grant from the NIH and started this study, and then I joined as part of the Fogarty Fellowship. It is a prospective cohort study, and so it's hospital-based surveillance of encephalitis in both children and adults, and so patients who come in to the hospital and meet the case definition at one of the study hospitals are then hopefully enrolled. And it's a collaboration between University of Washington, where the PI is, and the U.S. Naval Medical Research Unit in Lima, Peru. And this study was funded by the NIH Fogarty International Center through an R01 grant. And I'll talk, like I said, a little bit more later about the Fogarty Center. So the locations for this study, it started with 8 hospitals in 3 cities. So Lima, there were 5 hospitals, including 1 pediatric hospital. Trujillo is still along the coastal desert, but much farther north. And then Iquitos, like I said, is in the jungle region, so we had kind of a diverse geographic representation. And then later it was expanded to Cusco and Arequipa, which are down in the southeast. So inclusion criteria, again, it's hospital-based, and so any patient who was at least 28 days of age, so we were pretty much excluding the congenital causes of encephalitis, but including children who are older than 28 days of age. So the main inclusion criteria was acute onset of neurologic symptoms. And so that could be altered consciousness or seizures or coordination problems. Any of those was considered neurologic symptoms. Plus they had to have at least one or more, at least one of the following symptoms. So neurologic symptoms plus fever, headache, CSF pleocytosis, so many white blood cells in the CSF, and imaging like an MRI or CAT scan or an electroencephalogram suggestive of encephalitis. And patients were excluded if they had subacute or chronic neurologic symptoms, if they were very small, even though they were at least 28 days of age, if they had been a preemie or were very small, or had findings suggestive of bacterial meningitis. We were really trying to include the encephalitis patients. I wanted to say also, this is a pretty broad definition, and so it has a higher sensitivity. If you look in the literature, there are different inclusion criteria for encephalitis studies. This one is fairly broad because we wanted it to be sensitive and capture more patients, but it is a little less specific. But the neurologist, as part of the study, reviews the record and examines the patient, so we were able to get detailed clinical information about these patients. So patients were interviewed using a standardized questionnaire about basic things like demographics, history, clinical symptoms. The physician performs a complete physical exam and records the findings, and a CT or an MRI if indicated. If the patient could not afford that imaging, a lot of patients have to pay out of pocket for medical care, then the study actually provided it. As part of the study, a blood sample and nasopharyngeal swabs and rectal swabs were taken for testing, and cerebral spinal fluid via a lumbar puncture was also obtained and used for testing. And this was not an extra procedure for the study. Lumbar puncture is standard of care in Peru, and so that we fortunately didn't have to add extra procedures. It's just part of the care. So in the laboratory, we did basic studies on the CSF cell count, differential protein glucose, herpes PCR of both the serum and the cerebral spinal fluid, and IgG, so serology for herpes, and enterovirus testing, also testing for various arboviruses that exist in Peru, 20 different arboviruses actually, and also cryptococcus, tuberculosis, and HIV testing. And patients did receive pre and post test counseling when they got the HIV test. So for patient care, if herpes was suspected, then the physician team started IV acyclovir. And IV acyclovir actually is not available in Peru, and Joe Zent's team was able to bring it in and provide it for the study. And so I was actually really proud of this study and happy to be a part of it, because we helped create generalizable knowledge, but we actually also helped make a difference in those individual patients and provided them with a medication that they otherwise wouldn't have had, and that is really life-saving. Like I said, the head imaging was also provided if patients couldn't afford it. Herpes PCR results were reported to providers within 72 hours. If it was positive, obviously they would continue the acyclovir. If not, they would stop it. And then patients were asked to come back for a follow-up visit in 2 weeks and repeat the questionnaire about any ongoing symptoms. So the basic results, so far there have been 690 subjects enrolled. A little over half have been male. The mean age is 26 years, and the range is 3 months to 86 years. And subjects under 20 years actually comprised almost half of the study population, so that was interesting. There were a lot of young patients, unfortunately, who had encephalitis. So the most common symptoms of patients who presented were headache, malaise, just generally not feeling well, and nausea. And also about a third of patients had respiratory symptoms like cold symptoms and GI symptoms, actually, like vomiting and diarrhea. Neurologic signs, so again, this was part of the enrollment criteria, any type of neurologic signs. So all patients had to have some type, but within that, the majority of patients had some type of altered consciousness. They were lethargic or whatever. A good proportion also had seizures and neck stiffness. Fever was actually present in only a little over half of patients, interestingly, and only 18% had that classic triad of fever, neck stiffness, and altered consciousness. Oh, this shouldn't be, oops, that should be headache instead of neck stiffness. That's for meningitis. And the median CSF white blood cell count was 10 cells per millimeter cubed, but and it was mostly lymphocytes, which is indicative of viral infection. So. But that was kind of interesting, actually. So encephalitis typically does not have a very high CSF white blood cell count, but it is elevated over the norm. But 10 was a little lower than I expected, actually. So I'm going to focus the rest of this talk, on the herpes infections. Like I said, they did testing for a variety of other pathogens, but the results are still being compiled and analyzed, and so I don't have all of that information right now. I do have the herpes information, which was the focus of my research, so I'm going to be presenting that. So as you can see, as I said, the total number of patients enrolled so far up to the analysis that has been done is 690, and so of that, patients who had evidence of herpes in their cerebrospinal fluid, so that's a confirmed case. There were 62 of those. And of that, 35 were type 1 and 8 were type 2. So moving on to probable cases. So probable was defined as an IgG seroconversion. There were different criteria for infants, but basically if someone had negative serology and then converted to positive, that's pretty strong evidence of an acute infection and a recent infection. And so we had another 50 cases that fell into that probable category. 22 were type 1 and 4 were type 2. And then lastly, if herpes was present in their blood, but we did not find it in their CSF, or if they didn't have evidence of a seroconversion, they were considered possible cases, and there are another 10 of those. Moving forward, we limited the analysis to confirmed and probable cases just because they're more specific and we have more confidence that those are actual HSV. But I'm pretty convinced that these also, if someone comes in with encephalitis symptoms, we don't find another cause, and they have herpes running around in their blood, then it's pretty convincing that they have it, but we didn't include it for the analysis. So focusing on the herpes patients, the 112 subjects that had confirmed and probable were significantly older, so the mean age was 33 versus 25 years, and that was statistically significant. Some of these, I did a lot of the initial analyses up until about a year and a half ago, but the latter analyses, including more subjects, was done by one of my colleagues. And so sometimes I think this should be median age. I don't know if it was normally distributed. I think it was, and so that's why she used mean. But I apologize if there's some flip-flopping between median and mean. But anyway, they were significantly older, which was interesting. And patients with herpes were more likely to have headache, that wasn't surprising, more likely to have nausea, and more likely to have adenopathy, so swollen nodes, usually in the cervical area. They also had significantly higher white blood count in their CSF. That was about 25 versus 8 in all the other patients. And fever and seizure, cough and rhinorrhea were actually less common in herpes infection, but that wasn't statistically significant. I was a little surprised actually about the fever and seizure. Herpes, as you saw, is a very severe infection, and typically we think of patients coming in with high fevers and seizures. And so it was interesting, though not statistically significant, to see that it was a little less common for herpes. And then other characteristics and signs and symptoms that we looked at didn't differ significantly between those with herpes versus those without. So they also, as part of the study, tested for other co-infections, and so I will say that they weren't able to test for these in all of the patients, and so these percentages are among those that were tested. HTLV is human T-cell lymphotropic virus, and that causes some forms of leukemia, and also can cause a chronic neurologic condition, causing spastic paresis and other things. There is a research interest with some of the investigators there, so that's why they tested it for it, and there are certain areas in Peru where patients have this much more commonly than other areas of the world, and so they did test for that. HIV, there were a number of patients who had HIV co-infection, many of whom did not know it, so it was good that we were able to tell these patients that they were infected, but there was no difference, no statistically significant difference between those with herpes and those without, how many were HIV co-infected. A number also had syphilis and also had norovirus, but again, no significant differences for any of those. So next I'm going to focus the talk on comparing the different types of herpes encephalitis, so type 1 versus type 2. Among the 69 subjects that we, with confirmed or probable that we knew, we were able to determine the HSV type, about 17% had HSV2. And that is actually higher than we expected and higher than compared to other studies. So the California Encephalitis Project was a huge, really well done project of study of encephalitis in California, and they found that about 11% of herpes encephalitis cases were due to type 2. And they had 1,500 patients enrolled, and out of that, 5 of the 45 herpes infections were type 2. And in England, another large encephalitis study, they found that 8% of herpes was due to type 2. So these were both large studies, and this is also becoming a very large study. And you know, it's a little bit higher, and we'll have to see if that is maintained as we move forward and enroll more patients. But it's very interesting, and we really don't know the causes for these differences. But we did have a higher proportion, as you can see with the percentages, and also a higher absolute number. So the California Encephalitis Project enrolled almost 3 times more than we have so far, but they only had 5, like I said, and we had 12 so far. So it's really interesting. So this is the age distribution of type 1 and patients with type 1 versus type 2 encephalitis. And so the turquoise you can see is herpes type 1. It's sort of bimodal, but it's pretty evenly distributed among all the age groups, definitely more in the kids. This is a little surprising that it's less in this age group, but pretty even. But as you can see for herpes type 2, it stops dead after age 40s. And so it's really distributed towards the younger age groups. Again, we don't think we're getting congenital infections because those usually present within the first month of life. And so this is really heavily skewed towards children and also towards kind of the middle age group. And so some of this may be due to sexually acquired first infection with HSV2 that then goes on to cause encephalitis. We really don't know the reasons for these differences, but it's pretty striking. So summary of the findings overall, herpes is the primary cause of encephalitis in Peru. That's what we're finding so far. I didn't present the results, like I said, of the other infections, but based on preliminary findings, they are much, much lower than herpes. And even combined, herpes is definitely the leader. It caused 16% of confirmed and probable cases of encephalitis where we found an etiology, and that's consistent with other reports. Patients with encephalitis had pretty much nonspecific presentations, and most did not have that classic triad, and they had varying neurologic signs. And so herpes typically, like I said, is tropic towards the frontal and temporal lobes, and so you can see specific signs with herpes encephalitis, but not always. And all patients in this study had pretty nonspecific signs. And fever was present in only about half of patients at presentation, and that was for all encephalitis patients. This is interesting because, again, if you're in a location that has limited diagnostic capability, the clinical presentation and the exam are really going to be important for figuring out what's going on. But if about half of patients with encephalitis are coming in without a fever, that really makes the diagnosis difficult in some situations. And also, this is important for other studies because other studies of encephalitis, in those studies, fever is actually an enrollment criteria. And so if future studies use fever as an enrollment criteria, it's more specific, but they're actually probably missing a lot of cases of encephalitis. So in terms of herpes, patients with herpes encephalitis were slightly older, like I showed you, and more likely to have headache, nausea, and adenopathy. Herpes type 2 was responsible for 17% of all confirmed and probable herpes infections, and that was more than we anticipated. We're looking into the reasons for that. And patients with herpes type 2 had a distinct age distribution, definitely younger than patients with herpes type 1. So the strengths and limitations of this study, one of the strengths is it's the first comprehensive surveillance study, hospital-based surveillance study of encephalitis in Latin America. We had a large network that covers diverse regions and performed extensive testing on the patients. There was a potential bias towards severe cases, so this is hospital-based, and so patients who ended up going to the hospital were captured, and patients with transportation. So obviously, if they couldn't make it to the hospital, some of these are in very, very rural areas, and so if they couldn't make it in, they couldn't make it into the study. Also, testing for non-infectious etiologies was not included. There are etiologies like NMDA receptor and autoimmunity that cause a significant proportion of encephalitis, but we were not able to test for that. And some infectious etiologies may also have been missed. It was pretty comprehensive, but like I said, there's hundreds of viruses that can cause encephalitis, and so we couldn't test for all of them. And we did have a small number of subjects with confirmed and probable HSV2, and so we're looking into the reasons for some of those differences, but it does limit the statistical analysis. But again, this group of patients is more than other studies, and so even though it's small, we have the advantage of having a lot more patients than other studies have been able to look at. So policy and practice implications. So it's important to think, how can we put this information to good use? It's good to get information out there, but you really have to think about how you can help people with the information, and it's important to do public health and assessments, but you always have to try to follow up that with an intervention or some sort of action to help the people that you're studying. And just a little sidebar and advice for projects. I think most of, if not all of you, are in the MPH program and have to do thesis projects. And it's really important as you're designing your project to think about the end result, how it's going to help people, and how you're going to get that information out. Simply presenting it or publishing it is helpful, but it's really important as you're planning it to figure out what you're going to do with that information. And so, for example, a lot of people do KAB, knowledge, attitudes, and belief surveys for their projects, which can be really valuable and are nice for thesis projects because they're easier to do in a short term. But as you're planning it, think how you're going to get that information out. How is your information going to affect and help people who are doing the public health practice? And how are you going to get that information to the people so they can use it? Anyway, enough of my little sidebar. But so for this study in particular, it will be important to expand and prioritize herpes testing for patients with encephalitis. So substantial portion of patients with encephalitis in Peru had herpes, and so it's really important to get the message out there for clinicians to be thinking of it and to help build capacity to test for it in Peru and other countries. Intravenous acyclovir, like I said, is not available in Peru, and the oral version is not absorbed well enough to treat encephalitis. And so my study colleagues are in the process of talking with the Ministry of Health to try to get that available for an ongoing basis in Peru. So that will be really important because it's so important to help people survive. And then future research to further characterize the etiologies and the epidemiology of encephalitis, and also looking into why herpes type 2 encephalitis was more common in this population. So I'll talk a little bit about a nested case control study. And so, like I said, I joined this project that was ongoing and starting to build up, and I did a lot of work related just to the general research project. But then as part of the Fogarty experience, you have to have your own project that can fit within that, and that can be completed or at least started within the time that you're there. And so I decided to do a case control study looking specifically at herpes encephalitis and what are the risk factors. Because, as you all know now, most people have herpes encephalitis, especially type 1, and only a very small proportion go on to develop encephalitis. And we have no information other than age about why certain people are at risk for that and other people just don't get it. And so eligible cases were patients at least 28 days of age who were enrolled in the broader surveillance study and had confirmed herpes in the cerebrospinal fluid. And then we have two sets of controls. And so first of all, patients who are enrolled in the encephalitis who are HSV negative. So if they test positive, they become a case. If they test negative, they become a control. So it'd be nice to compare herpes versus other causes of encephalitis. And we already have a captive audience with these patients who are enrolled, so it's pretty easy to study them. But we also wanted to look at patients who are completely healthy, and trauma patients are actually nice to do this because they have had some sort of accident, but usually they're otherwise healthy or basically representative of the general population. And so patients with minor trauma who come into those same hospitals, so theoretically the same catchment areas, we interview them regarding various things that I'll talk about in the next slide and use them as another set of controls. So data collection, it's basically an expanded survey. So we ask a lot of detailed questions about demographics, family size, household members, livestock. Livestock we don't think is related to the transmission of herpes, but it's a nice proxy for people who live in rural areas or some sort of farm environment. Cooking method I decided to ask about because a lot of people are exposed to smoke, and one thought is that patients who have maybe a cold or have irritation in their nasopharynx and in their head area, maybe that sets them up for the latent infection re-emerging and going to their brain. We also talked about different exposures like travel and smoking and sexual activity, medical information, of course, and then we capture laboratory results when possible. I also started a study of genetics related to herpes, and so some geneticists like to say that there's no such thing as bad luck, that most people who get whatever type of disease have some sort of genetic predisposition, and sometimes we know what it is and sometimes it has yet to be discovered. And so there actually have been some case reports of patients with herpes encephalitis who have some sort of mutation in the cytokine pathway. And so toll-like receptors, UNC93B is a gene that's been shown to be different, and tumor necrosis factor. These are all genes that have been shown to be altered or somehow different in a few patients with herpes encephalitis. And this could be a clue why some people go on to get encephalitis and most people don't. These are case reports only, and so the big question is, are these isolated findings, or could this explain why some people get herpes encephalitis? And this could have possibly prevention, but also treatment and outcome implications if we can help look at this at a population level and see if this is contributing to more than just a few cases. So I wanted to end with a few words about the Fogarty Center. It is a small branch of the NIH that was established in 1968 by Lyndon Johnson. It's named for Representative John Fogarty, who he was a tireless advocate for international health research to reduce suffering and foster peace and prosperity throughout the world. So this is, you know, a pretty standard concept, and most people understand this, hopefully, these days. But he was really ahead of his time back when he was serving as representative and really pushing for this. He actually pushed for a specific branch of the NIH or some sort of more formal establishment, but while he was living, it never actually happened, but Lyndon Johnson established it the year after he died and named it after him. The current budget for the Fogarty Center is $69 million annually, which sounds like a lot, but compared to other branches of the NIH, it's actually pretty small, especially considering all they do, but they do a lot of good work. So I hate to just read the slides, but I'm going to read this quote for you. So within the Fogarty Center, so the Fogarty Center as a whole provides research grants like R01s and R21s to get research started, but they also have a specific program for fellows and scholars, so for students and people who have recently finished their training. So it provides supportive mentorship, research opportunities, and a collaborative research environment for early stage investigators, both from the US and from low and middle income countries. It's for doctoral scholars, that's the scholars part, and those can include medical students, PhD students, possibly some other students. It depends on what type of scholarship or fellowship you want. And then also postdoctoral fellowships, which includes post-residency. And so I did my pediatrics residency, did the preventive medicine residency, and then right after that was able to do the Fogarty program. So the timing worked out nicely. And these are typically one-year fellowship programs. The program has changed a little bit since I did it. It used to be run primarily by Fogarty Center and Vanderbilt, but they have since decentralized it, and so there's 5 different academic centers that help run these different programs. And there are additional opportunities, like there's a Fulbright Fogarty Fellowship, HIV Corps in Africa, and other opportunities that you can look on the website and see if you're eligible for. And the website is, there's no www, it's just fogartyscholars.org. It is a pretty competitive process and application. When I did it, and I think it's still the same, is scholars just had to apply based on their merit as a student and doing interviews. But fellows, if you're later in your career, you actually have to design a project and apply with that project in mind. And so part of your assessment is not only your assessment or your capability as an individual applicant, but it's basically like a review process where they review your proposal. And I actually found out about it first during my first year of preventive medicine residency, and I think Carolyn had actually sent a link, and that's how I found out about it. But I found out about it just a couple weeks before the deadline, and so I put together an application and emailed people, but I actually didn't get it. But the nice thing about this is they provide you the reviewer comments, and so like they do with other grants, they provide you comments about what were the strengths and weaknesses of your application. And so that's really nice because then you can go back and apply again with that in mind. And my particular weakness was that, it's only a one-year program, and so you really have to have a detailed plan of how you're going to accomplish the IRB and everything within a year, or at least get a good project started. And so I was able to tweak that and was accepted the following year, which worked out timing-wise better anyway. So acknowledgements for this project, obviously the Fogarty Center, they provided the R01 for the general research and also for my fellowship. Joe Zunt, the PI. Sylvia is the co-principal investigator in Peru, who I worked with quite a lot. Nico was one of the study coordinators and really a wonderful person to work with. And obviously all the study hospitals and the co-investigators and foremost the patients who were involved in this study. This is just a picture of me and some of the team at the hospital in Trujillo. We were doing one of our site visits and were able to talk with the study investigators and the physicians and make sure everything was running smoothly. This is a picture of my son, who was born in Peru while I was there. So he's 4 months in this picture, but he's a little over 2 years old right now. But I wanted to show these because, number one, he has a bib that says, I love ceviche, lomo saltado, all these wonderful Peruvian foods. And then he's wearing in this the typical chullo hat that you wear in Peru. But I wanted to show this in part because many people have families or want to start a family, and it's hard to pick up and leave, and it can be more difficult if you have a family or want to start a family compared to someone who's young and single, but it is possible. I actually brought my dog to Peru. It was a lot of paperwork and hassle, but we couldn't leave one behind, and so we were able to bring my dog. Easier for Peru than probably other countries, but it is possible, and it is possible to either bring your family or start a family if you're doing one of those. So don't rule it out just because you have a family if possible. So with that, I'll finish and take any questions. Oh, and if anyone is interested in applying or just has questions about CDC or Fogarty, I have cards, and so just come introduce yourself and I'll give you a card. So, any questions? Yes?
Where did you hear about patients who diagnosed with HIV?
So they did have pre and post test counseling, and so if they were positive, they got counseling as part of that, and so the counseling included how do you manage from now on, making sure that they got appropriate care and understood the risk for transmission and how to protect, their wives or husbands and stuff like that. And so the main tenet of it was the counseling and making sure that they were educated about the disease and were tapped into the care. But we didn't provide treatment, antiretrovirals or anything as part of the study.
Is that treatment available there for them?
Yeah, it is. Yeah, it depends on, like in many places, it depends on if they have access to medical care and if they can pay for the treatment. There is some availability for people who can't pay for the treatment, but it kind of depends where they live and, how well they can access the medical care. So most patients, it seemed like, were able to get the proper treatment, and there are some programs set up for that. That's a good question. Carol.
Thanks very much, Christina. You mentioned that part of the purpose of the program was to enhance capacity. What kinds of things was the study able to put in place that you could sustain for sure, as opposed to things you were hoping you would sustain?
Yeah. So that's a good question. They were able to help build some labs or expand some labs in some of the hospitals, and so they provided funding. I don't know if it was directly through Fogarty or other funding, but they provided some funding and also guidance for building and setting up some of the laboratories. So in Trujillo, for example, they really expanded. And the laboratorians who were involved in the study also did training to the lab workers at the hospitals, and so they could actually do the testing moving forward. So it was both kind of tangible things and also less tangible, like training that were provided. Yes.
The hold up of the IDA cyclovir and the cost?
That's a good question. I don't know. I think, well, acyclovir, actually, while I was there, was really difficult to get. Some of the manufacturers stopped producing it, and so I spent a lot of my time calling various countries trying to get IV acyclovir so the study could continue. And so some of it's access, some of it's cost, and some of it is just the government trying to focus on the most important things, and not knowing that herpes was so prevalent. And so I think part of it was just not knowing how necessary it was. I think it was multifactorial. Other questions? No? Okay. Thank you all.